Next we will go to the coordination. Coordination is cerebellum system examination. Okay, from top to bottom, what you will examine in the patient from top to bottom. Okay, we will go for a coordination. Now we will examine the cerebellar system examination. Okay, from top to bottom. First we will consider the head. What are the things you see in the head? Head in the cerebellar system affection, there can be a titubation, the nodding of the head can be there. Okay. Now next coming to the eyes, the nystagmus. In all the direction you can ask him to look. ऊपर देखो, इस तरह देखना, इस तरह देखना, नीचे देखना, up देखना. Okay, so nystagmus you will ask him, examine the nystagmus. Nystagmus, as we discussed in the third examination, in a cerebellar system, if right side is affected, the patient will have a right side nystagmus, only first component towards right side, and he will fall towards the same side. In cerebellar system, all the signs are same side only. Okay. Next, speech. Speech, as we discussed in the higher mental function, in a cerebellar system, it will be a dysarthric speech, scanning speech and staccato speech. Okay, scanning, artillery, they will pronounce like artillery. Then staccato speech, there will be explosive quality to the voice. Okay, the explosive quality to the voice is due to the incoordination between the nasopharynx and the pharyngeal muscles. There will be incoordination. Usually you get in an alcoholic cerebellar affection. Okay, right, speech. So next coming to the hand, upper limb. What are the things you look in the upper limb in a cerebellar system? The finger nose test you have to do in a cerebellar system examination. Ask the patient to touch the nose with the finger abducted. जैसा मैं करता हूँ उस तरह करना, है ना? इसको टच करना और 4-5 साथ कर, और इस साथ से करें. ओके, आंख बंद कर करिए, करिए, इस साथ से करिए. Yeah, bas. Okay. So here the three things you will look while doing a finger nose test. It does smoothly. That is a smooth movement of the hand. Okay, when it brought from outside to the touch the nose. That is a smooth movement. That is called as synergy. If there is a cerebellar system affection, there will be decomposition of the movements. So they'll bring like this. Okay, in a haphazard manner, the decomposition of the movement will be there. Okay, that is dyssynergia. The next thing what you will observe in a finger nose test is, okay, whether he correctly approaches the target. But if there is a cerebellar system affection, either he falls undershot or he will overshoot. Either he falls undershot or overshoot. That is known as dysmetria. Then the third point what you look is in finger nose test is, while doing finger nose test, no, he may overshoot. That is pause pointing. As we have already discussed in the 8th nerve, pause pointing can be tested by to distinguish vestibular and cerebellar system. So we will do it again, pause pointing. हाथ ऐसा रखना, कल किया था ना, आंख बंद करना, आप ये ऊपर कर नीचे डालकर मेरा फिंगर टच करना. ओके, ऊपर नीचे लाइए. Yeah, suppose is normal now. Suppose if there is a right-sided cerebellar affection is there, right hand will drift towards the right side. If right vestibular damage is there, both the hands will drift towards the right side. Okay, next. One more improvisation of the finger nose test is finger nose finger test. आप ऐसा करना, उसके बाद मेरा उंगली को टच कर आपका नाक को टच करना. सो पहले ऐसा करना, आंख बंद करके, आंख नहीं, आंख ओपन करके. ओके, सी ऐसा करना, जब मेरा उंगली को टच कर यहाँ करना, मैं उंगली को टच कर यहाँ करना. ओके, ओके, करिए. पहला इस तरह करिए, आपका नाक को टच करिए, मेरा उंगली को टच करना. Yes, okay, this is finger nose finger test, improvisation of the finger nose test. Then in the upper limb, what other two tests you do in cerebellar system examination? Okay, right. Holmes rebound phenomena. What you do is you will try to flex, you apply the resistance, and then suddenly you will release the pressure. ये ना, ऐसा करना, ठीक है, ऐसा करना. करिए. Then suddenly leave it, but he checks. Suppose if there is a he checks there. Suppose if there is a cerebellar affection, he will go and hit his face. Okay, this Holmes rebound phenomena, this is due to hypotonia. This is due to hypotonia. Okay, then in the upper limb, one more thing which you can test is dysdiadochokinesia. Dysdiadochokinesia is tested by doing rapid alternating movements. So ask the patient to do like this or ask the patient to do like this. Okay, इस तरह करिए, फास्ट करिए, हाँ ठीक है, इस हाथ से करिए, ओके ठीक है, इस तरह करिए, yes, so you can do it, or you can tap on the floor, you can do like this, इस तरह करिए, okay, right, you can do for it. This is a test for dysdiadochokinesia. Now next, in the lower limb, you look for a same like a finger nose test, heel, knee, shin test. We'll do that. Okay, knee heel test is done by asking the patient to touch the tibial tuberosity, drag it along the shin and bring it back again. Okay, मैं जब बोलता हूँ इस तरह कर इस तरह यहाँ रखना, फिर इस तरह कर इस तरह करना. Okay, heel, knee, shin test. करिए इस, yes, करिए एक और बार, इस फुट से करिए, करिए करिए, yes, this is a knee heel shin test. Okay, so in knee heel shin test also you will see all the three things. Okay, whether there is any smoothness of the movement to determine any dyssynergia is there, whether it overshoots or undershoots, dysmetria is there, or overshoots pause pointing is there. Okay, that is knee heel shin test. So next in the lower limb, pendular knee jerk, the more than 3 oscillation if it is there. Thus we'll check now. ढीला छोड़िए आराम से, कोई दर्द नहीं होता, कुछ नहीं, ये ढीला छोड़िए, ढीला छोड़िए. Okay, now we'll do the pendular knee jerk. So in between the patellar and tibial tuberosity, you just give a jerk. See, you can see the reflex. Okay, yeah, see, you can see the reflex. See, this is the reflex. See, so nicely came. Again nicely came. ढीला छोड़िए, कुछ नहीं करते, ऐसा करिए दोनों हाथ, हाँ टाइट से करिए, टाइट से करिए. See, it is a knee reflex. If it is more than 3 oscillations, it is a pendular knee jerk. Okay, next is gait. So one is whether the cerebellar gait is a wide base gait. Wide base gait, they will swing to the ipsilateral side. There will be ataxia. So to check any mild disturbances there in the gait, okay, you will do the tandem walking test. Okay, tandem walking test is done by ये है ना, इस तरह walking करना, करिए. Yes, this is a tandem walking test. Okay, right. Okay, now after tandem walking test, the one more test in the cerebellar examination is walking around a chair. I want a chair. So you put a chair, ask the patient to go around it. For example, while going from a like this clockwise, if there is a right cerebellum is damaged, he will fall towards the right side. If there is a left cerebellum is damaged, he will fall towards the left side. Yeah, एक और बार. Okay. The other sign in cerebellar system examination is tremors. So they'll have intentional tremor while approaching a objects. Even while doing finger nose test, while approaching the fingers, you can make out the tremors of the cerebellum while approaching the nose. Then handwriting, you can ask the patient to write on a paper, sheet of paper. In a cerebellar system affection, there will be a macrographia. The handwriting will be a very wide, big letters will be there in a cerebellar system affection. Okay, so these are the cerebellar signs which you will look. Now, how to localize the cerebellar system diseases? So mainly there are 3 lobes: flocculonodular lobe, the cerebral hemisphere, and vermis. Okay, flocculonodular lobe is known as archicerebellum. Okay, the vermis is known as paleocerebellum, and the 2 lobes are known as neocerebellum. If flocculonodular lobe is affected, we deal with the equilibrium. Patient will have nystagmus, vertigo, and other kind of things. And the disease which affects flocculonodular lobe is medulloblastoma. Vermis, the midline syndrome will be affected in alcohol. It will be affected in alcohol, the vermis. Okay. So usually if the vermis is affected by alcohol, they'll have gait ataxia. While walking, they'll have a problem. There is a gait ataxia. The disease which affects the vermis is alcoholic cerebellar degeneration. Then both the cortex which the patient is affected, the patient will have the limb ataxia, the hand will be a problem, the limb ataxia, or appendicular ataxia. The disease which affect these both the cerebellar hemispheres are strokes, tumor, and multiple sclerosis. So next is the pancerebellar. Pancerebellar is all the things will be affected. The vermis, flocculonodular, and both the hemispheres. The pancerebellar affection is usually due to the hereditary cerebellar ataxias like Fred's ataxia, spinocerebellar ataxias, and paraneoplastic syndromes. Now, how do you distinguish ataxia of cerebellum from ataxia, sensory ataxia? Okay. Sensory ataxia, they will have a high stepping gait, which we will discuss again in the gait disorder. High stepping gait will be there. Reflexes will be absent, the ankle reflex will be absent. There will be absent sensation in the lower limbs. Whereas cerebellum will have a reeling and a lurching gait. Okay. Reflexes will be normal, sensation will be normal. Other cerebellar signs will be there. This is how we distinguish a cerebellar ataxia from a sensory ataxia. One more thing in the motor system which I left out to tell is, in the motor system power examination, the one important single test which you have to do in a motor system examination to find out minimal weakness is pronator drift sign. Okay, now I'll show how to do pronator drift sign. Okay, ask the patient to hold both the hands like this. Okay, then 30 seconds he has to hold like, then close the eyes. If there is a mild minimal pyramidal weakness, that hand will slightly pronate like this. So still more weakness, it becomes like this. Still more, there will be adduction. Then the hand becomes like this hemiplegic posture. Adduction, flexion of the hip joint, flexion of the wrist joint, adduction of the fingers. So it goes like this, hemiplegic posture. So one single test in a motor power examination is a pronator drift sign. Okay. Another is if there is a parietal lobe affection. Okay, if both the hands are outstretched, the one hand will go up. Okay, in a contralateral parietal lobe affection due to the position sensation abnormality. Okay, the one hand will go up. So, and one more test to detect minimal pyramidal weakness is, apart from pronator drift sign, the swinging arm test. In a swinging arm test, if the patient is asked to move like this, suppose if right hand is weak, that hand will move slowly. You can make out my right hand is moving slowly. Okay, so this is how you make out the difference. Okay, now after discussing the cerebellar system examination till now, I want to tell the difference between UMN and LMN lesions. UMN lesion is corticospinal tract. Spasticity will be there. Deep tendon reflexes will be exaggerated. Plantar will be extensor, which we will discuss in the reflexes part. Okay. Then group of muscles will be involved, whereas in a lower motor neuron, individual muscles will be involved. What do you understand by that? For example, this is the external rotation of the shoulder joint done by infraspinatus and teres minor. Teres minor is supplied by axillary nerve. Infraspinatus is supplied by suprascapular nerve. Though this movement is supplied by both different nerves, that both the muscles will be affected in UMN. So, a group of muscles will be affected irrespective of the nerve supply. Whereas in a lower motor neuron lesions, individual muscles will be affected. The skilled activities, okay, especially the hands, will be involved predominantly in upper motor neuron lesions. Wasting is not a feature of upper motor neuron, is a feature of lower motor neuron lesions. Fasciculation is a feature of lower motor neuron lesions. Okay. These are some important differences between upper motor neuron lesion and lower motor neuron lesion. So, what is the usual posture in a hemiplegic person? Upper limb, because of the anti-gravity muscles are overactive, more tone. These are the anti-gravity muscles, flexor groups in the upper limb. There will be adduction, flexion at the hip joint, flexion at the wrist joint, and then pronation. Okay, upper limb will be like this. Lower limb, extension at the hip joint, extension at the knee joint, Okay, then there will be a plantar flexion and inversion. Okay, and then the leg will be adducted also. This is hemiplegic posture in a corticospinal tract involvement. Adduction at the shoulder joint, flexion at the elbow joint, flexion at the wrist joint, then pronation. Lower limb, extension at the hip joint, extension at the knee joint, plantar flexion, inversion. Okay, this is hemiplegic posture. So we discussed the nutrition, tone, power examination, coordination. Next we will discuss the reflexes.